Thank you very much. Thank you, Pradeep. It's very nice speaking on this beautiful morning. I shall be speaking on a very fancy topic. It's everybody wants to diagnose as a case of a polypoidal choroidal vasculopathy. It is taken as one of the greatest mimickers. So, what it has, PCV has been diagnosed as a special entity almost 2 decades ago, but more frequent and more elaborate and more confirmative diagnosis has been done with the advent of multimodal imaging almost 5 years back. It is most commonly misdiagnosed with a CSCR with fibrin. This is how a classical PCV looks like. If you see on left hand side an OCT which take us one scan, radial scan, you can see those double layer sign and a finger like PED. If you see the FFA on the left side, you see a hyperfluorescence, and with the corresponding ICG, you see those polyps and the BVNs. This is a more clear picture of the FFA and the ICG. You can see on the right side the polyps, the classical polyps on ICG with the BVNs, branchiovascular network. This is again a classical PCV, but if you have taken a scan, a radial scan, this may not be, you may not sometimes get a very classical PD in OCT. Yet when you do the ICG, you will again see those polyps with BVNs. This is a more clear picture of the hyperfluorescence on FFA and those classical polyps and the BVNs. Sometimes even in ICG, you may not get initially the polyps and the BVNs, so you have to go through the phases as late as almost 15 minutes to get for those polyps. So if you just see this initial ICG, you may sometimes miss those polyps and you tend to underdiagnose. Not every CNV or PD can be picked even on the ICG. So though you may see those classical pictures on OCT and you do this FFA and the ICGs, and you may not pick up those polyps and the BVN. So here it is, you have to go on to the other investigative modalities to diagnose. Now, this is a case of a diabetic. No, it has been diagnosed as a case of a diabetic retinopathy because the patient was diabetic for long. So he was being treated as a case of a diabetic retinopathy. But then somebody decided to do a ICG in this because of the picture on the fovea. If you see this, hyperfluorescence in the fovea, and if you see those ICG, you can see those BVN. So here is a case where it's being treated as a diabetic retinopathy, but on doing ICG, you diagnose as polyps and now being treated as a case of a PCV. This is what I was talking about when you have done this ICG and you can see those BVNs. Sometimes when you are over enthusiastic in diagnosing PCV, you can just over diagnose a case of a simple AMD as polyps and BVN clinically also. And once you get an OCT done on this, you can just see those drusen's, just simple drusen's. And on FFA and ICG, you can see on the FFA, you can see the multiple hyperfluorescence. These are the drusen's. And on the right side, you can't see any polyps and BVNs in ICG. So you can over-diagnose sometimes or under-diagnose. So not everything which hypersenescence is PCV. Especially if you're doing a ICG, you can see, and on the left side you can see hyperfluorescence. These are the leaking, or these are the drusen's. On the right side, again you can see a hyperfluorescence, hypersenescence on ICG. These are again drusen's. So sometimes are falsely labeled as polyps. The advantage of ICG over FFA is that even with a large bleed, you can do ICG, whereas in FFA you can't do this because you will see only block fluorescence. So these are tense PD seen on ICG. The masqueraders. Now don't miss Gofi for Pluto. This is very important. Here, if you see this, you will just label this as a case of a cystic edema. Will you not? You just see one scan and you start thinking in terms of a cystic edema. Now, the moment you change the direction of your scan, go and scan in other directions, you start seeing something different. What is that? So this is what you see an SRF and a PD. So your diagnosis has changed from a cystic edema to a case of a PCV. This is what I was talking about. This is what is the PD, and you do the OCT of the other eye. Very important in all these cases. Please do not miss examining the other eye. You sometimes over diagnose. You are very enthusiastic in diagnosing, just seeing one eye and start diagnosing. Please see the other eye. So you see the other eye, you see those PDs, then you say yes. Why there should be a cystic CME in one eye only? So then you say yes, it is different. All the cases of CME, with the new multimodal imaging coming in, you have actually changed the role of investigative modalities. Here is a case of a CSC. If you these multicolor images, it's pseudo colors, you can see those greenish tinge. These are on color imaging. These are typically seen as a case of CSC. Those yellow colors, whereas in case if there is an AMD, you will see those as a yellow color. Then you do a FAF, and there you can see those hypofluorescent ring. That is quite characteristic of CSC. Of course, once you do an angiography, you will see those hyperfluorescence, that typical ink blot pattern. And when you do the corresponding ICG, there you see this hyperfluorescence because of the leaky choroid. So what are the lessons drawn in these cases? That do not scan in just one, do not look at single B scan image. Never take out a printout. In case of any doubt, please go to the console, see all the scans yourself. You don't depend on just one scan, because you don't know the optometrist must have taken it only one scan, and then you are not able to form a diagnosis. So please go yourself, see all the images, look at the fellow eye. It's very, very important. Never diagnose a thing just looking at one eye. You have to correlate clinically. Always it is the best practice is to clinically see a patient and then correlate all your investigative modalities. And the most important is your own brain. Please, your own judgment in diagnosis any of these conditions. Would a swept source OCT help in such cases? What is the advantage of swept source OCT is that it takes a wider cut. It's a 12 millimeters cut, which can take right from the vitreous to the choroid. So in one section, you are able to see everything. So this is what is the yellow, this thing is there. You can see the depth of your choroid. So in these cases, simultaneously it takes, as I said, acquisition of images from the vitreous to the choroid, and it is easier to comment on a single scan. This is a case of inner latent cyst, So what the diagnosis comes to mind is that it could be a differential diagnosis, could be a mactal, telangiectasia, DME, CME, BRVO, or a vitreomacular traction. So once you do a swept source OCT, you can get a scan right from the vitreous. Here you see this is what has happened as a VMT, which is pulling the retina and causing a cyst formation. Otherwise, normally it can be misdiagnosed as a mactal. This is again in a lamellar macular hole, and on swept source OCT you can see those, and when you see the other eye, it's a normal fovea. So you diagnose a case of a lamellar macular hole. This is again an impendi full thickless macular hole. Again, sometimes being misdiagnosed as a case of a mactal. When you see the other eye, it is normal. So that rules out mactal. So what are the lessons drawn from VMT, VMA, or a macular hole? So look at the vitreous attachment to the retina. It's very important. The radial scans are always better than the horizontal raster scans. Must look all the B scan sections before commenting, and the fellow eye. Always examined because certain conditions bilateral, you tend to diagnose mactal in one eye and then you see the other eye it's normal. So you please rethink your diagnosis. This is what I said about Swepso's OCT, that it takes a 12 millimeters cut section with enhanced vitreous view mode. You can diagnose a case of a VMT straight away on a case of a Swepso's OCT. Sometimes fluid may not be because of the macular edema. You know, you see this picture, you say that it's a CME. But once you do the other investigative modalities, see what it happens is that you do other investigation, OCT, angio, the FAF, then you see, yes, it is a case of a foveoschisis, X-linked foveoschisis. So again, you know, what was your diagnosis, what you think, your brain starts thinking in terms of CME, and then you end up landing as a case of a foveoschisis. Again, this is what I was talking about, the hyporefractive space. Yes, again, you must start thinking in terms of mactal. Definitely, once you see the other eye, because even the laminar macular hole, it can be misdiagnosed as a case of a LMH, but you see the other eye, in case of it is affected, then yes, you have to start thinking in case of as mactal. You see this color pictures, you can see those telangiectatic vessels and bilateral involvement. So again, you just diagnose as a case of a mactal. This is a case of a telangiectasia with an, you see this again, can you see this, again leaking the hyperfluorescence on FFA. This was missed out. So just as a case of mactal, but it is associated CSC again. So what is the role of this, that you have to correlate, go step by step, do one investigation, follow up with other investigation to confirm your diagnosis. And this is the last slide. I would like to emphasize that here is a case of an exudative RD. But how did OCT help in this case? You know, if you see the choroid, it's quite homogeneous. It's absolutely homogeneous, and there is no subretinal inflammation and no vitreous inflammation. So this is not a case of a simple exudative RD. So this was a 33 years old lady. We were able to give the picture of this. It was a case of a metastasis from adenocarcinoma. So the OCT helped us to zero on to a diagnosis. When the lady went for a PET scan, we started thinking in terms of metastasis, and yes, it was a case of a metastasis. So wherever possible, you know, even with your Cirrus machine, OCT machine, please use EDI mode. You know, these can sometimes help you clinching a diagnosis to make you think, or think which normally you tend to miss out. And please use your OCT hardware EDI mode whenever available. And the role of OCT angio cannot be overemphasized because it's a non-invasive. With this, you can diagnose so many things which otherwise mimics PCB. Thank you.